Good afternoon. Okay, there's several of our FEPA team that are joining us today that we'd just like to acknowledge. There we go. So if we could have anyone in our FEPA team that's present, stand up quickly. You can see along the top, we have Dr. Lyle, Dr. Esther Erdei, Dr. Derek Ferguson, and Isabel Beasley who are joining us, and our research team. We also have Tim and Angel somewhere around here, and they're representing the Rapid City office, and we also have another office that recruits for FIPA on the Shining Reservation. So basically, we have a randomized trial that we're building off of. We're in phase 2 of our FIPA study, and in the initial study, we did a intensive education intervention for the children with asthma with the hopes of improving their asthma control. We enrolled 104 children with asthma into that. It was randomized, so half the group got, or the non-intervention group got their usual care and just written asthma information. And the other group that was in the brief intervention received more intensive in-person education as well as like case management follow-up and access to the asthma educator. We did find that there was a protective effect seen at 1 year post-intervention, and you can see in the slides there the difference between the green and the blue line, where initially there's kind of a gap, and we saw that the group that received the asthma education had fewer emergency room visits in the first year after that education, but after that year, that gap kind of closed, which tells us that the education was initially effective but didn't sustain beyond the year. So the lesson is there that education needs to be ongoing and not just a one-time flash in the pan and think you're good. And this kind of gets to the case control portion of the FIPA-1 study. We enrolled a total of 324 children between the ages of 6 and 17, and we did environmental measures, blood tests for allergies and inflammation, as well as DNA testing. A third of these were children that had asthma, 2/3 were case matched by age that did not have asthma, so we can see the difference between the kids that had asthma and those that didn't. And the samples from the FIPA-1 study, we asked all the participants if they were interested in having their samples kept for future use, and we've continued to use those samples for additional purposes that relate to asthma. So if you're a participant that's ever asked that question, it is really valuable for our studies to have ongoing access to those samples as long as they're good. What we found is that nearly half of the children with asthma were poorly controlled. So there's something called the asthma control test. It's got 5 simple questions that asks about how their symptoms are with asthma, and almost half of them have poorly controlled asthma, which is really concerning, and another reason that we need to reinforce more education for these kids. We also found that most of them, about 52%, had a rescue inhaler, which is the classic albuterol, but only 24% were using controller medications, which it should be a lot higher with that many that are uncontrolled. So we're seeing under-prescribing and underuse of those controlled medications, like the Advair Discus and some of them you see advertised on TV. And that's something that we've given that information back to the clinicians and encouraged them to prescribe more readily.
Yes, so, but this is just the iPad. Oh, I see. So what we were also looking at is how we could use immune measures as everybody donated biospecimens. For example, identifying the type of asthma that people are having on the reservation. So why is it important? Some asthma are induced by exercise, for example, but we barely see that in our children. What we see is high IgE. This is a type of immunoglobulin that we use for clinical diagnosis of asthmatic symptoms, and they are very prevalent among the enrolled participants. And so we following that, is there any change, for example, by season, and how these measures also alter? We also see increased atopy, that's a capacity to generate allergic reaction, for example, to skin and exposure directly to the body. We also measure other markers here. I don't want to go over them, but just to show that we also, as Ray mentioned, studying the genetic alterations, and that's from UCSF. Dr. Torgerson is sitting there, wave. And then her laboratory were doing these measurements and targeted genome analysis. And the variants that they found they potentially have a strong association with asthma, so it makes sense to use these to confirm also our clinical dedication to this work. And I gave back to Ray because she, in the next slide, she was doing this type of communication back.
So one of those reasons that we used the samples was to do a chip assay for the whole genome that basically helps us look at everything that the genes show. It's over 500,000 looks at a gene. And what we found was the MYH7 gene, we found 2 individuals out of 324 that had this, that puts them at risk for some cardiac issues. And you can see that people that have that gene, there's about 60% that actually have symptoms or issues from that. So it's important to get that information back to participants, which we did, and help encourage them to do some testing of their heart to make sure there's no issues already, and make some lifestyle changes to really take care of their heart since they're at risk for that.
So currently, as we mentioned, building on this previously collected group, 324 individuals in Cheyenne River community, we expanded by re-enrolling, recontacting people we knew they were willing to do so. Remember, all of the human subject work requires consenting, and in those processes, we ask them to mark for future contact. Is that allowed if we use the information for later time, and that's what it's happening, as well as we expanded the study to capture urban conditions, because it's not just the reservation. I gave a big shout out for Kim and the Rapid City Office of Missouri Breaks, so thank you everyone. They do a wonderful job contacting and enrolling, and Connor is there collecting samples. He's not here. But we are looking into other measures during asthma, which asthma development or influencing outcomes in asthma, which is, for example, traumatic events during childhood, how that also relates to symptoms that they may be more severe. What we also try to do is to move away from the negativity, and then also finding potentially protective factors, that they are in the community, they are in the family. So we expanded for the benevolent childhood experiences measures. ACE is, which is an adverse childhood event capturing, that's a CDC promoted standardized method. But we would like to also see protective factors in the community, because we believe that's also a better way to communicate about problems, as well as helping the families how to enhance that. It's also in line with other parental research that's been done through Missouri Breaks. So other issue, and that's very important to consider, thank you, that they might have other factors in the environment, as you heard. Dr. Tileris talked also about talking PM, so exposures to particulate matters in the homes. We would like to also capture that. We have purple air monitors going to be used, and then also long-lasting, so-called forever chemicals being measured in the serum samples, and that's going through also with Dr. Torgerson. UCSF has a research excellence center that we applied for support, and that's how we generated that data as well. Yeah, just to short, I'm very interested in, I'm an immunologist by training, and very interested in how certain infections also relate to chronic disease development. Not just when you are infected, but later how those are actually influencing. And it's known that the respiratory syncytial virus, which is shortened RSV, many basically science communicated to people, RSV is very, very significantly influence asthma development if the baby is getting it earlier than 2 years of age. So what we see is incredibly high, really, really high prevalence of these, the indication that that kids being exposed to this virus in the community samples. So we would like to further study those. We employ influenza detection and rhinovirus, parvovirus. These are all respiratory infections. And I'm also in my laboratory, we also do vaccine response because one of the main concerns is if asthma as a condition, it's a hyperreactive condition, but maybe not allowing the immune system to generate protective, normally beneficial response, right? So that's what we try to also consider. And I give it back to Ray to talk about our enrollment numbers.
So you can see here where we're currently at. This is just as of a few days ago when we updated our numbers, and the breakdown of different age groups. We have a pretty even split of males to females, which is wonderful. And as children, new children that are recruited to the study, we identify if there are cases, meaning they have asthma, or controls, meaning they don't, as well as the root contacts like we're following up with from the first phase of HIPAA. If you know anyone with asthma and sharing your work, please send them our way. And then just quickly, I can go through the next phase. We're doing a pilot study also through UCSF where we're going to put purple air monitors in the homes and find out what's going on in the homes, kind of similar to some of the other talks that have been given, to understand what symptoms are tracking with different air conditions and potentially identify solutions to things that can be controlled in the home to better manage asthma. We're also doing some conversations with the community advisory group for Missouri Breaks on what a successful asthma intervention might look like, whether that's policy related or education. And some of the suggestions that we got back so far that I think are really interesting and we're excited to pursue is working with our tribal housing authority, as well as private homeowners or renters, to improve standards and education of those maintenance workers, because I think that's something that unfortunately, if you're somebody that's renting, it's a lot of things that are outside of your control. But if we can educate the people that have the authority to make those changes in the home, that can really mean a big improvement in asthma symptoms. And they also suggested working with school nurses to provide education, because oftentimes the kids that need it the most aren't the ones that are in the clinics that have access to the physicians and the nurse educators, but meeting those kids where they're at. All kids are at school, right? And then we're also having discussions with our health committee, social media content. We've done radio shows, print media, and are hoping to do some conversations with groups of parents and children to better understand what their needs are and how we can best address them. And I think that's it. So there's all the contact information for the folks that were referenced. Thanks to all the participants in the tribe for doing this research.
We'll continue on. My name is Lyle Best, and we started a genetic study of preeclampsia or toxemia of pregnancy at Turtle Mountain Community College back in 2004. And as we were interviewing for someone to work in the lab, a young lady came along and she indicated interest. She had a bachelor's degree in psychology and was working as a telemarketer, but she seemed to have lots of promise and was willing to tackle something new. So she quickly learned the lab techniques, but her forte was really in recruitment and visiting with people and explaining the study and so on. And after a few years, she decided to move on and get a master's degree in epidemiology and later a doctorate degree in epidemiology from the University of Minnesota. Is now a professor at the University of North Dakota. So I'd like to introduce Dr. Melanie Nadu, and not, you won't find many better people to talk about the importance of sovereignty and health scholarship than Melanie. So please welcome her.